First of all, happy Valentine's Day. Thank you for joining us tonight for this topic. And it's a topic near and dear to my heart, so I don't have a heart's emblem outside of my symbol here, but I really care for spinal cord injury patients. That's one of my passions. And so since Dr. Ziegler and Guy and our good friends at TBI allowed us to kind of pick topics that we're interested and passionate about, I thought I'd talk about spinal cord injuries tonight. I want to thank my partner, Dr. Oskuyan, to put the program together because it's out of town. And so we have 5 of our fellows giving vignettes of care surrounding Charcot spine patients in the following. But happy Valentine's Day. Thanks for being here. And I'm going to give a brief intro and also a quick pitch. Tomorrow night, we'll have an inaugural evening with a spine surgeon. We have none less than Dr. Alex Vaccaro with us. Dr. Ziegler and I will host a 1-hour meeting where we have an informal chat about what makes him tick around spine surgery, where he sees our specialty going, and what brought him to where he is as the leading spine expert in our era, at least according to Expertscape. So please tune in again tomorrow night. Now to the topic at hand, catching up with Charcot, the Charcot arthropathy thing, and I want to dedicate this hour to my late friend Ed Farrer. He's a spine surgeon in Washington State. He was a T2 paraplegic for 10 years after a pickup truck with a drunk driver folded him over. And he ended his life with physician-assisted suicide May 2022 when he developed ascending Charcot arthropathy that rendered him basically tetraplegic. He was a paraplegic T2 and he first lost one arm, then the other one. And so this is very tragic. He's a super active guy, very, very fit. He was also the bicycle safety advocate of our academy for many years. So this is in his memory and in the memory of many spinal cord injury patients and what we as spine surgeons hopefully can do. And I've heard from many people in my travels around the world why we care about Charcot spines. They're happy to have that extra motion. Well, this is a patient that I've still not cured or treated because I can't cure her, but she's in her late 50s. And she is very, very heavy. She's lost a leg from diabetes, and she has the most grotesquely retrofolded sacrum imaginable. She basically has no sacrum left. She's sitting on her panniculus, and she has had over 50 surgeries with flap coverages and desperate things here or there. I have not dared to reconstruct it yet because she had these draining sinuses. She now has a panniculectomy. She's had an ilio-urostomy, and she's had a colostomy done. So at some point in time when her soft tissues clear up a little bit more, we will go in the back. She's actually done quite well with these soft tissue procedures and she's had no breakdown anymore. But this is what happens if you don't deal with this problem. And this is a very nice lady. And again, just to make sure that everybody sees what actually is going on, her sacrum is basically completely retroflexed and she has this cavity in her lower instrumentation area that basically bridges 2 levels. So this will be a high morbidity, high acuity surgery. Now, what can we do and what should we do? This is a different case scenario, a 45-year-old female with C5 quadriplegia, 20-year history of this paralysis. She had dysautonomia, which got worse and worse. She had crepitus. She didn't have real pain. She just didn't feel well. She was pale. And she had this destructive arthropathy, which in typical fashion was treated as discitis osteomyelitis. And the question I could ask everybody is, are you going to wait and see, biopsy, brace, kyphoplasty surgery? In the interest of time, I will tell you what I did. I decompressed this, I drained this, I washed this out. There was no significant infection in there, and we stabilized it, and she actually was very, very happy with this. And I'll talk more about the post-op rehab later. So how do we know what's going on there? This is a specific disease entity that we can singularly attach to a neurologist from France named Jean-Martin Charcot, a very game-changing person who literally single-handedly developed all of these various entities. Little known fact, he was the one who suggested that something called paralysis agitans be renamed Parkinson's disease. So he's not a selfish person. But he also, amongst many other things, developed the concept of the Charcot foot, a more or less lack of proprioceptive innervation of a high pressure entity. On a side note, again, he is also responsible for having developed the concept of histrionic paralysis. There was a large litigation move around the so-called railroad spine when for the first time human bodies were subjected to the high speed of steam trains at 20 miles an hour plus that led to paralysis disorders, and he identified this to be a histrionic disorder. It's also known as railroad spine. You can look up yourself. He worked, and he was a chairman, he worked in the famous Hôpital Pitié de Salpêtrière. I've lost some accent aigus there, but it's a massive neuropsychiatric hospital right next to the Sorbonne University in Paris. And he has single-handedly also had these kind of students amongst him. So this is an amazing legacy that he's had. The point here is that if we have no protective pressure sensation on major weight-dependent joints or active joints, they will decay. So the famous beef eaters, for instance, they actually don't stand still. They have masses at micromotion so that they shift their cartilage wear and tear. But the sensation of pain is actually a helpful thing to avoid overuse and prevent breakdown. And that was one of his key insights. And all of us as orthopedic surgeons know the infamous Charcot feat, and the treatment of this has dramatically changed over time, when now an anatomic reduction of these displaced feet is preferred over amputation procedures. But it is safe to say that we as human beings have a very poor understanding of proprioceptive disorders, and we all understand the differential diagnosis, which includes, again, syphilis, vitamin B12 deficiency, but especially diabetic neuropathy. Ankylosing spinal disease can lead to that. Hypertrophic osteoarthropathies and spinal cord injuries can do that. And I suspect, but I have no proof, that heavy-duty opiate use can also create that. So this is one of those things that's now becoming more and more clear. And again, the posterior column pathways are actually well described, but there's a certain organ, the tendon organ of Golgi, which is very important in terms of this pressure sensation transmission into our afferent tracts. And again, this is one of those under-recognized qualities of our neural system that I think bears a far greater thought and understanding. And this is a famous pictogram out of Gray's Anatomy of the tendon organ of Golgi. So back to clinical care, patients with spinal cord injuries continue to live nowadays, better resuscitation measures, better initial care, and they want to be active, and they are active, and they are very active. And again, they use their spine, they abuse their spine, and we frequently have to treat the injured zone with surgery to realign the spine, to facilitate rapid mobilization. We want to minimize our fusion levels as much as possible. We want to have an aggressive, well-performed rehab program. And one of the major problems for paralyzed patients, as I could see in my friend Ed Farah, is the daily transition from vehicles like a wheelchair into a car, for instance. The transfers are a major shear creating instance that creates a torque and a lateral bending arm on the spinal column, which can lead to breakdown. So we want to think about multiple things, and this is, again, one of the key first points I want to make is infection, discitis, osteomyelitis are always the first thing that radiologists pick up on, or at least say they can't rule this out. And in fact, this is a very misleading thing, because basically, as we're looking at this, the major problem is actually not the infection. It's a structural derangement, just like a Charcot foot, with a superinfection being possible. So what's the problem? Incidence, presentation, and how do we as healthcare professionals play a role? Well, all these things conjure to a bad constellation. The incidence is relatively rare. It's never been really formally assessed, and we'll have some great presentations by our fellows in rapid fire format following. The presentation is usually non-specific, such as the case 2 that I showed demonstrates. And healthcare professionals like us have not been really targeted in our care of these patients. It's not been a very systematic thing. So the incidence, again, you'll hear a better paper about this, but it's relatively unknown. Again, the major problem is that these things happen occasionally, and we're mainly relying on case reports and case series. And again, the world literature just a couple of years ago was about 85 patients when I put that together. At Harborview, we contributed to one of the papers, and I'm not going to dive into greater details, but these are 2 of the leading papers that had more organized, pursued patients. And again, you see here a list of all the various presenting symptoms. You'll have a brief talk about this following this. I'm not going to read this out to you, but basically what I've seen is that patients who have an unstable Charcot arthropathy don't do well. They look sick, they are sick, they're very susceptible to diseases, and they have weird pains. They lose their sitting balance. They're not themselves anymore. The time to onset has been discussed many times, and is usually 10 years after spinal cord injury, but there are many variables such as patient size, length of instrumentation, health of motion segments below that matter. And again, one of the simplest things to do is to get a sitting X-ray and a CT, if possible, and an MRI also. What is not necessary is doing serial needle aspirations. It's common to kind of look for infections, but that's truly not the main problem. The main problem is that there's a structurally unstable spine that will progressively destroy itself, regardless of what bracing or mobility adjustments we try to do. And so the classic thing is that we have an amorphous hyperostosis, we have regional osteolysis, we have massive hypertrophy, and a loss of alignment, which is progressive. These are the same hallmarks for a foot Charcot arthropathy, for a knee, a hip arthropathy, as well as for the spinal column or the shoulder. It's always the same phenomena throughout. So there's usually a significant delay in diagnosis. There's usually a 2.6-year average in delay of diagnosis, and a number of patients in this very limited series actually died within a year simply from sepsis or from organ failure, because these patients usually get hit with hard antibiotics over time. The basic treatment principles that we've formulated over the years are to do a debridement, to do antibiotic beads if there's a fulminant infection with necrotic tissues, and do a staged reconstruction procedure, usually anterior-posteriorly. And we usually fuse to the pelvis for anything that goes into the lumbar spine, because that's been the most inviting, best fixation strategy to not fall apart under the tremendous loads that many of these patients who are also very large exhibit. Here you see a failed lumbar-pelvic fixation on the left and a revision on the right with quadruple rods. More about that later. So as a Harborview experience, I'm going to flash through that. We had two different cohorts that we could compare, an older historic one and then a more modern one. And basically, we could find that with modern instrumentation going to the pelvis, we could achieve a much better survival and a far lower hardware failure rate. Of course, a fusion, as Dr. Lieberman always reminds us, is what we ultimately want to achieve. So those are the main things. With all this metal, do they actually heal? They actually will heal very well if you have stable fixation and a good, healthy environment that you've created, sometimes on a staged basis. This is a very near and dear patient of mine, a 42-year-old patient, had multiple plastic surgeries for a weird sacral decubital ulcer that this very healthy man with a T9 paralysis had developed. Plastic surgeons couldn't get the flap to close. It turned out this was CSF leakage from his sac, and this is a picture on his wedding day. We've remained good friends over time, and he's become a national spinal cord injury advocate. He's a very successful businessman also. So conclusion of this talk before I pass on to Dr. Jared Cook, who'll talk about presentation specifics with a scientific article, is to identify the lesion, to treat it, at least monitor it, to not needle these patients because the infection is not the main problem, and to advocate for prevention and mobility strategies. So just a quick pass off to Dr. Jack Sigler, who did his fellowship also at Rancho Los Amigos. Jack, any thoughts, anything that I left out whilst Jared gets his slides up?
Oh, Jens, that was a beautiful summary. An entity I was never exposed to as a resident in New York City, but when I did my fellowship with Henry Bowman, where part of his job was running the spinal injury center at the Cleveland VA, he had collected stacks of x-rays on a half a dozen of these patients and asked me if I wanted to try to put them together and write a paper, but I was kind of blown away, never having heard of this. And then in my years at Rancho, obviously, it became more of a problem, particularly below complete spinal cord injuries. And everything you said is exactly right. You have to be aggressive and you have to be long in your instrumentation and fusion to restore stability in order to get it to heal. But almost always there was a radiology report that said, suspicious for osteomyelitis, and that was always everybody's first impression. So, it's an entity that certainly, if you're taking care of spinal cord injured patients, you have to be aware of. And the other part of this is post-traumatic syringomyelia, which sounds like was the issue with your friend, where syrinx can ascend multiple years after a spinal cord injury just due to abnormal hydromechanics in the CSF. So, and that will result in progressive cephalad loss of function in people who very much depend on every single nerve root for their day-to-day survival. So that's just a terrific introduction. Thank you.
Thank you. So we'll dive deeper into sub thoughts. Maybe you and then anybody on the chat room or in the panelist box can also weigh in. So Jared Cook is one of our fellows, and he's going to talk about clinical presentation. Is that right?
Yes, sir. So I'm just going to pick up where Dr. Chapman left off. So important things, the diagnosis is often delayed because of, just the way that the patient presents, as Dr. Chapman said. But it's often 17 years on average after a spinal cord injury, that they actually get diagnosed with this. It's something that shows up, later. Their presentation tends to be, pain, deformity, just often kyphosis, changes in their neurologic status, sometimes just audible clicking with motion, increased spasticity, any bladder changes, autonomic dysreflexia sometimes is the first thing that they show up with. Anyone who wants a screenshot of what that is, right there. The risk factors for this are having surgical treatment for spinal cord injury. So in 70% of the cases, it's seen within or below the surgical site, which is what we're seeing in in the images here. By the way, this all this stuff is from Charcot arthropathy of the spine from Journal of American Academy of Orthopedic Surgery from 2022. So that's where you'll find this one. Also laminectomies, long fusions, more than 5 vertebrae in thoracolumbar and lumbar regions are your risk factors as well as recurrent infections. So for diagnosis, the presence of impairment of proprioception and pain sensations, just what you're going to see. You see radiographic bony destruction, resorption, new bony formation, and just evidence of nonspecific chronic inflammation on histologic exam if you were to do that biopsy. But as Dr. Chapman pointed out, and just don't continue to biopsy this. Some things as far as that differential goes, since it is kind of a broad differential, things that we see in Charcot, we've got disc destruction, hypertrophic osteophytes. It's really just disordered bone remodeling and deformity. So one of the differentials is osteomyelitis. So generally speaking, for discitis, osteosclerosis at the end plates, or little to no facet joint involvement. Although I did want to point out this is something that we've seen very often. You have this destruction of the end plates, involvement of vertebral bodies in these in these infections. This is what shows up here, so you can't really hang your hat on that description. As far as if you're dealing with a tumor, could be localized to one vertebra. You can get mass going out into the spinal canal. This is again, this is a typical case that we see here. So that's kind of what you're seeing there. You don't have that reactive bone formation that you see with your Charcot. If you're looking at degenerative spinal disease, the disc space will be preserved. You get osteophyte formation, no soft tissue component, and then if you're tuberculosis is also on the differential there, a lot less common in the U.S., but we do get that here. So bony destruction, paraspinal masses, epidural fluid collections, but you don't have that bony reaction that you see with Charcot. A couple of things just in the workup. You won't have so it's as a non-infectious entity, you don't have that big rise in ESR and CRP. You might just have some non-specific elevation, whereas with discitis tend to have leukocytosis, your ESR and CRP up. Although keep in mind that cultures are negative half the time. On your biopsies, fibrosis, granulation tissue, just the standard pseudoarthrosis evidence with Charcot, whereas in discitis, you may be able to see the infectious pathogen. If you're looking at tumors, you can have elevated neutrophil to lymphocyte ratio, elevated platelet to lymphocyte ratio, trabecular destruction, neoplastic cells, just about there, and just atypical cell patterns, things that you don't see on, with Charcot, and then with degen, normal ESR CRP, it just generally does not look like Charcot. So those are really the main things for the presentation. I'll pass this over to our next speaker, and we'll stay tuned for the case.
Dr. Jim Hicks, thank you, Jared, very helpful. Dr. Jim Hicks is going to come up and talk about historical perspectives. Again, these are rapid fire vignettes in terms of some key points that hopefully are meaningful to our community tonight. We thank you for your attention on Valentine's Eve. We know it's a special evening. Of course. My partner, Dr. Amir Abdul-Jabbar, is here also for commentaries. Fire away, Jim.
So again, in brief, Charcot, spinal arthropathy, CSA. So we're dealing with a decreased afferent innervation, as we were saying earlier. Joint degeneration occurs in the spine with unchecked inflammation. The spine becomes unstable and progressive deformity occurs. This can be painful for these patients, but we always need to be aware of this subtle progressive neurologic deficit. Historically speaking, in the classic literature, you'll see the effects of tertiary syphilis, tabes dorsalis affecting that posterior column, leading to a neuropathic spine. Fusion for this pathology is reported as early as 1931 to 32 with Drs. Steindler and Key. Casting, bracing, and non-operative management was generally the rule until about the 50s and 60s, to my understanding, where fusion for painful and unstable lesions became more common. And then in 1978, Dr. Slaba et al. Described spinal cord injury as the cause, and a cause which is vastly more common today. And this is that 1978 article. I think the references are very interesting, just looking at the dates and the discussion of surgical treatment and how to treat these neuropathic spines. And of course, with early surgical intervention for spinal cord injuries, whether that just be simple decompressions or instrumentations, back in the day, these patients had very interesting and historical constructs to contend with, as we can see here from this article out of the Spine Journal back in 2010. So as you can see, the hooks and ladders, you'll have your wire constructs, the Harrington rods, etc. 1991, recommendations from Devlin et al. Small lesions, posterior fixation with anterior grafting would be suggested in this article. And then restore the sagittal plane, anterior first, if rigid or a large lesion. Leave no, quote, intercurrent unfused segments between the new and old fixation segments. And fusion to the pelvis, according to this article, was not always necessary, although that has evolved. So getting into Dr. Skewing's suggestion for an article, and obviously we can see the famous authors here. Interesting points that they did make is that this Charcot arthropathy averages, again, as Dr. Cook was saying, about 17 to 19 years. And it's more prevalent in the motor deficient Asia category, so your A's and B's. And 80% of what we see today is the spinal cord injury variant of the Charcot arthropathy. Other causes can include a prior tumor resection, spinal cord ischemia, and myelomeningocele, essentially making up the other 20% in this article. Tertiary syphilis, much less common these days. Non-traumatic causes of Charcot spinal arthropathy typically take longer to manifest, and up to 30 years or so, say for a tumor causation. Interesting chart in the article. You can see traumatic, and you have the spinal cord injury patient population. And audible clicks is also something that the patients will complain of at times. You can see the levels of spinal cord injury as compared to where you're seeing the Charcot arthropathy, and we're seeing it mostly in the lower segment of the spine, in the lumbar spine. This is a familiar picture from earlier Dr. Chapman's talk, but this is an example of a failed single rod construct and then transition to the quad rod construct and extension of the pelvis, which is more common today, also including an anterior column reconstruction. So again, this evolution around the 2000s, single rod to quad rod, whether that's in the revision or the de novo setting for Charcot spine. And aggressive debridement and anterior column reconstruction is now standard. Complications have remained steady in this patient population. Infection, wound drainage around 20%, reoperation rate overall about 35%. Lumbosacral osteoarthrosis also remains a problem though, even if you do fuse to the pelvis, something to watch out for. Current management, quote, intralesional debridement, circumferential fusion, and 4-rod lumbopelvic fixation, and utilization of BMP is also suggested from this article.
Excellent, thank you. So our next speaker is going to be Chris Seidel. He's going to talk about the pelvis. As he's getting ready, Izzy, you and I have had many debates about more metal or less metal, and you're obviously an absolutely superb surgeon. I've seen you work personally. Were we just not very good surgeons that we had all these rod breakages? Did we not do adequate cage grafting in the front that led to these hardware failures? Or would you agree that maybe these extremely biomechanically challenging patients with no protective torso innervation require more metal? What are your thoughts?
I am very, very reluctant to say this, but metal is the answer for these patients.
Oh, wow.
It is definitely more metal, more fixation holding them up. We don't understand the biology. We can't control the biology. You can still throw BMP in there, and it just doesn't seem to work. I do think we are relying on an artificial limb, so to speak, to keep these patients sitting in their wheelchairs and functional. And that artificial limb can be 2 or 3 points of fixation on each side of the pelvis with 3 or 4 rods, and maybe even some kind of anterior intramedullary spinal rod, something going right up and down that's going to hold things with multiple washers and different pronged washers going up and down to give them some kind of anterior pillar. So I think this is the one time where I would say metal is the answer.
And you're not saying that because it's Valentine's Day and you want to be a nice guy to me?
No, it's got nothing to do with Valentine's Day. And by the way, I didn't get the chocolates this year, Jens. What's up?
Losing it. Well, verbal chocolates here.
Thank you.
Pelvis. Should we go to the pelvis as a routine thing? And if so, how so?
Good questions. So like Dr. Chapman mentioned, I'm going to be talking about Charcot arthropathy as related to the pelvis and our modern fixation techniques available. I'm not going to belabor this too much because we've kind of already talked about this, but Charcot spinal arthropathy really has 2 main theories for its etiology. There's the neurotraumatic theory that we've kind of talked about, secondary to spinal cord injury, and then there's a neurovascular theory where there's hypervascular regions underneath the subchondral bone from systemic disease. This leads to increased breakdown, microfracture, and instability over time. So there are several things that need to be considered when deciding whether or not you're going to extend your construct to the pelvis. So as we've kind of highlighted this paper multiple times already in that paper out of Harborview, Jacobs et al., they noted that extension to the pelvis with a 4-rod construct can prevent development of new Charcot joints distal to that construct and prevent hardware failure as well. However, the price you pay for extending to the pelvis is a loss of mobility. And so this group did a really nice case study where they showed good fixation into the pelvis, but what happens was the force was transferred down below, and they found that there was an increased incidence of proximal femur fractures secondary to this loss of mobility. So with that said, there are a few options we have for going into the pelvis, and they include iliac screws, modified iliac screws, and S2AI screws. So the iliac screws, this is the gold standard, has the longest track record. These are placed at the inner table along the iliac wing, starting at the PSIS. There's some pros and cons. Very strong fixation doesn't violate the SI joint. However, it does require a more extensive dissection. You can require a rod connector because it's off plane with your other tulips. It can be prominent and cause gluteal pain or wound breakdown. Next would be the modified iliac screws. This uses a more subcrestal position, also allowing for very strong fixation. So the pros here would be, again, very high fusion rate, very strong fixation. That subcrestal start point reduces prominence. That can reduce some of those issues with gluteal pain or wound breakdown. The cons are that compared to an S2AI, though, you're doing more of a dissection, and there's still a similar risk as with iliac screws to the neurovascular structures on the lateral side of the iliac wing and or the interpelvic contents. So finally, S2AI screws. This is kind of a midway start point between S1 and S2 foramens, crosses the SI joint superior to the sciatic notch. The pros of this is less dissection. That's clearly the benefit of this. It gives strong fixation, though that proximal alar bone is not great. The cons are that you can get SI joint irritation from this, and they have a higher failure rate with increasing age. So several studies have tried to determine the superiority of one of these techniques over another. This study out of World Neurosurgery, looking at 18 cadavers, 6 in each group, found no statistical significance between traditional iliac screws, S2AI, or modified iliac screws with regard to toggle or rod strain. Another study out of JNS was looking at acute failures of pelvic fixation. And so they found that there's approximately a 5% acute failure rate of pelvic fixation that happens at a mean of about 62 days after the primary surgery. Set cap loosening was the most common mechanism of failure. And then some notable factors found to be significantly associated with acute failures included a large pre-op deformity requiring a large deformity correction, whether or not a PSO was done, higher BMI, male gender. Interestingly, using iliac screws over S2AIs were found to be associated with failure. And then the diameter of the pelvic screw, anything less than 8.5 was associated with failure. So the takeaway here is that in Charcot spinal arthropathy, extending to the pelvis can help prevent hardware failure and development of arthropathy below your construct. So you have to be cognizant of these risk factors, though, for acute implant failure when you're going to extend down. And also, just be aware the loss of mobility is basically the price you pay for this.
Nicely done. Thank you. Thank you, Chris. Next up, I'll ask Mauricio Avila to come up and talk about, again, the subject of rod fractures and fixation from a different angle, that's from getting a fusion. Jack, in your Rancho experience, when you revised or when you did these Charcot fixations, did you try to preserve the rudimentary non-functional spinal cord core, the central neural sac, to allow for some alpha motor neuron transmission, if there's anything there, or some parasympathetic connections? Is there any merit to preserving the posterior main neural tube?
Well, again, most of these patients were Asia A, so most of them were complete paraplegics, and we didn't purposely try to disrupt the neural elements, but nobody, I think, was that concerned with trying to preserve function below a complete level. And in fact, we had 1 or 2 visitors who, from I think outside the US, who would comment that they sometimes would tie off the thecal sac to allow better access to the anterior column from a posterior approach. But we sort of cringed hearing that. But it's at that point in time anyway, there was not any concern for trying to preserve any distal proprioception.
And Izzy, Dr. Lieberman, I've seen how you do your own anterior approaches. They're amazing. In these patients, there's a very large, reactive, very ugly zone of inflammation. Would you still go anteriorly or anterolateral in these patients, or do you just go posteriorly around or through the neural tube?
It all depends on what you're presented with. You mentioned that some of these patients can become very obese and very contoured. The the belly, the pelvis, everything's sitting in an undefinable position. So there's a few that I have not gone anterior on. There's a few that we've gone circumferentially on. You put them in a lateral and you do a modified thoraco-abdominal to the front, and then you extend them from behind and you try to get as much as you can. This is a type of surgery that you have to be very creative in gaining access to the spine and recognize the hurdles that lay in front of you by virtue of their morphology, their body habitus, the pathology that we're dealing with. So there's no one answer here.
All right. Thank you for the comments. Mauricio, show us how we can avoid rod fractures. You gonna say more metal, or are you gonna do something else?
So I'm gonna switch a little bit because I think Garrett and I had a little bit of overlap topics. So I'm gonna talk about multiple rods and their nomenclature, which is one way to prevent rod fracture. So this was an interesting article by yours truly sitting in the first row, Dr. Chapman, talking about the nomenclature of the multiple rod constructs. So the big thing is it has been found that multiple rods, so more than the usual two, prevent rod fractures. So now I think basically everywhere people are putting more than two rods in this longer constructs. And so far we talk about with Charcot that you need to go long and go to the pelvis. So we're gonna be talking that this patient will need multiple rod constructs. And I think every time we are in conferences or different speakers will call different rods the different way. So I think this is a nice way to do it. So the primary rod are your two basically main rods that span the whole construct. And then I'll start showing you with some pictures the other type of rods. We have secondary rods, satellite rods, accessory rods, kickstand rods, and the delta rod. That's the only one that I don't out of the picture. But so here you have secondary rods on your left-hand side. They are in red. Let me put the pointer. So these.
Use the cursor. Yeah.
Yeah. Do you see the pointer there?
Yeah.
So they're here. So they are connected to the primary rod, which is what I'm highlighting here, which is key because that's the difference versus a satellite rod, which you can see here is a shorter rod that is not connected to the primary rod. So the satellite rod, it's commonly used if you do a 3-column osteotomy. So you only putting this two rods through your osteotomy and then not connect to the primary rod. These are the accessory rods. Some people also call it the outrigger rods. And these are fairly commonly used, especially because they're easy to place. You just have connectors and then just place them. They can be anywhere within the construct. Most people will do it in a place where you have osteotomies. And then the kickstand rod, the key here is you have an additional pelvic screw that is connected to this rod. And then again, depending on how high you want to go, you'll expand at least, let's say, the side of your osteotomies, and it could go as high as here. These are commonly used for coronal deformity as an additional rod. So that's very simple. I'm going to put this graph again of the way we call the different rods that we have. And then I just have a short conclusion here. So the accessory rods, again, the most common ones, they're easy to place. They're not connected to any of the pedicle screws, just to the primary rod. You have multiple options depending on the multiple connectors from the different companies. The satellite rods are the ones that are not connected to the primary rod. They just span the area of the 3-column osteotomy. They're usually not that long. And the kickstand rod needs an additional pelvic screw, and is connected to the primary rod, is usually used for coronal deformity. That's it.
Very nicely done. Thank you for this rapid overview. And we'll follow this up with a metallurgic discussion by Garrett. Dr. Dave Pauly from Minnesota dialed in. He's, as always, awesome, and thanks for joining us. If you want to be a panelist, please let us know. But he pointed out to not ligate the central thecal sac. You can take off nerve roots on one side liberally, he said. I totally agree with that. We never know what actually transmits somewhere, even a perceived Asia A patient. So I agree with him. Dave is live now, I think. Dave, can you unmute?
Hi, Jens.
Great to have you tonight. Tell us why we should not ligate the central neural sac.
Yeah, this comes a little bit sometimes from Milo kids where they still have some sort of weird preserved function that we don't understand, and I've seen that in my spinal cord injury patients as well. And I had one really unusual experience where I had a young gal who had a Charcot above her spinal fusion. And so that was something where we were very much trying to preserve the neurologic function. So the concept that there may be some preservation that we don't understand and that may result in some further deterioration is the reason that I've gone away from ligating the thecal sac and take nerve roots rather than the thecal sac.
Very well said. Stay tuned. The next brief
Yeah, Jens, can I
Yes.
just make a comment? It says you want to make a comment about the accessory rods and satellite rods. One of the things that I frequently see is individuals using the accessory rods will put the bend in the rod at the same place as their primary rod and then fasten it with some cross links or whatever it may be. And if you think about that biomechanically, that really doesn't help, particularly with flexion extension forces, because you're still bending at the same spot. And all you're really doing is delaying the failure of the rod from 2 years to maybe 3 years. So what I would recommend and what I try to do and most times is keep the accessory rod in a different plane with bends in different spots so that biomechanically you're disseminating the load. You're not concentrating it on one spot. And especially with these neuromusculars or the spinal cord injuries, where transfers generate such a tremendous force as they're swinging the lower extremities in their pelvis across, getting in and out of a chair or in and out of a bed, it really helps to stiffen and strengthen that construct.
Really a great insight, very well put. And I'll add to that, I think, and Garrett and I talked about that just yesterday morning, there's a lot to be learned still and discovered in our biomechanics labs and these things, and just getting our wording correct is very important. So Garrett is going to talk about rods, and then I want both you, Izzy, and Dr. Pauly to weigh in on materials and diameters.
Yes, thanks, Dr. Chapman. After we heard about from Mauricio to prevent rod fractures in Charcot arthropathy, I now want to focus in more detail on the impact of rod diameter and materials. So just a quick overview above my key points. At first, I'll start with an overview of rod materials, also the historical development by time, following rod fracture risk by material and diameter, referring to a recent systematic review and meta-analysis, and then followed by a conclusion. So at first, when we speak about rod materials, a very important name is Paul Harrington, who developed rod materials in the 1950s. At first, rods consisted of stainless steel, which has the advantage of strength and construct stiffness. But on the other hand, the disadvantages of kind of a supra-physiological degree of stiffness, which is also leading often to ASD, as well as a high resistance of bone screw interface, resulting in fractures. So there was a necessity for development of more physiological alternatives, which were found in semi-rigid rods, which improved the kinematics, but were also stable. Cobalt chrome and titanium, as two of the semi-rigid rods, had moreover the advantage of more resistance against corrosion. So the different materials differ in yield and facilitate strength as well as stiffness. Titanium and cobalt chrome, which are recently the most often used materials, when you compare these two, you see that titanium has a lower yield strength and lower stiffness compared to cobalt chrome. In the further development in 2007, there was a new material entering the market, which was polyether ketone, short PEEK, as a compliant radiolucent material. So the materials right now available are still stainless steel, cobalt chrome, titanium, nitinol, which is a combination of nickel and titanium, as well as PEAK. So the recent studies favor the use of cobalt chrome as well as titanium, but also in a recent meta-analysis comparing titanium and cobalt chrome, there were no differences shown in fusion rates as well as mechanical complications and infections in 2022. All right, I continue with this systematic review and meta-analysis from April 2022, which investigated the association between postoperative outcomes and complications with different rod materials and dimensions. They included adult persons diagnosed with any kind of spinal deformity, reporting also any surgical management for spine deformity using any type of rods. The exclusion criteria were only that they excluded children, as well as some specific study designs, such as animal or cadaver studies, case reports, editorials, commentaries, or letters. So just giving a quick overview of the Prisma flow diagram, they included, they first identified 1,260 studies between January 2010 and November 2020. After the selection process, they finally included 50 studies matching the inclusion criteria. Regarding the methods and statistics, the postoperative outcome parameters they evaluated were complications, which were rod breakage and certothrosis, as well as postoperative corp angle, sagittal vertical axis, and pelvic tilt angle. And in my speech, in the following will focus on rod breakage for sure. The qualitative and quantitative synthesis was performed as well as a meta-analysis according to Prisma guidelines, and the outcome reported had to match at least 2 of the included studies. Just the statistics, the dichotomous outcomes were analyzed by Mantel, Hensel, REM, as well as the chi-2 test used for chi-square test used for statistical heterogeneity. All right, when we look at the data of rod breakage, we see the comparison between titanium and cobalt chrome. There were 3 studies dealing with titanium rods included, and they showed a pooled risk of 0.12%. Compared to the cobalt chrome, which included 2 studies, this was a risk of 0.0%. So comparing these 2, we see that they are very similar results and no huge differences between these 2 materials. So concluding to the study, there was no evidence that rod fractures and functional outcomes differed by rod material and rod diameter, especially regarding the rod diameter. There was no comparison possible based on the rod diameter because only 6 or 6.35 rods were included. I think major limitation of the study was the large heterogeneity of the patient's populations as well as the surgical techniques. Similar to this meta-analysis, another recent meta-analysis showed an overall incidence of rod fractures of 12%, but without focusing on further characteristics like rod diameters and materials. So just to take a small glimpse of an actual project, comparing rod fractures and standard rod as well as multi-rod systems. Dr. Cook, who is with us here, allowed me to show his data. Just to give a quick overview, this project, which was recently submitted, is now under peer review. It was conducted by Dr. Cook, as I mentioned, as well as other fellows here from SSF. And when we compare the risk ratio of fractures in different time periods, right here as well as right here, we see that comparing the standard rods as to the multi-level rod, we have a decreased risk ratio in multi-level rods, as we see here in both time periods, minor 37 months as well as more than 48 months. But yeah, just to give a small glimpse, and the study, as I mentioned, is still under peer review. So to finish with my key points, rod fractures maintain a common problematic complication. As you all know, there's still this difference between flexibility or motion versus stability. There have been efforts taken by using new materials and diameters as well as the multi-rod systems, but still we have, as we see, a paucity of available data, and therefore further research is required. Thanks.
That's really nicely done. Thank you. And thank you, Jared, for sharing that slide. We'll ask Jared to come up for our final case as he's taking the podium. So I'll just throw this ball up as a toss-up between Dave Polly and Izzy, maybe. What should we gather now? Should we go back to titanium? Should we do bigger titanium? Should we just go multi-rods? Should we abandon chrome cobalt? What's the best idea?
I've abandoned the cobalt chrome rods. I think they're too brittle, and they do eventually break. So I just never really liked them. They're also too hard to work with. My preference is multiple titanium rods, putting the rods in different planes with as best fixation I can possibly get into the pelvis to act as that foundation to hold the patient up.
Well, so Jens, I know you like controversy. So Izzy and I are significantly divergent on our opinions about this. I like cobalt chrome because I find them easier to work with. And I found that for me, titanium is notch sensitive when I'm bending it. And so if you're doing pre-contoured rods, I think that takes the, patient-specific pre-contoured rods. I think that takes some of the notch sensitivity out of it. But I'm still not a big fan of titanium, and unless I'm dealing with an infection or a tumor. The other piece that I think is key is I always used to like to end the multiple rods sort of in a symmetric pattern. And then I think one of the things that we're learning is that we want to end them at different levels so that you have a tapering of the stiffness of the construct, and that may, in fact, lessen some of the fracture problems, so that if you have the accessory or supplementary rods, don't end them both at like, I don't know, L2, but maybe end one at L1 and one at L3, and that may help with the transition of the stiffness. I completely agree with Izzy on one point, though, and that is that we want the best possible fixation that we can get in the pelvis. And so I'm at a minimum, I'm using 4 SAI screws and sometimes even 6 screws, where I'll do 4 SAIs and then 2 sort of in the kickstand trajectory if I need 6 rods across the segment. We may just be kicking the can down the road, but I'll be retired and it'll be one of my partner's problems to fix.
All right. Now, to conclude things, last 10 minutes, Jared has selected a case, and I have no idea what this case is. So I'm very curious to see what you have. And maybe we'll have Jack Ziegler be the first discussant of this case.
Well, some nice foreshadowing off of that last comment. So we'll just get right into it. So here's a patient, history of spinal cord infarct at a T5 and T6, back when they were a teenager. And at this point, wheelchair ambulator, some good strength, just not enough to walk on. Neurogenic bowel bladder, non-drinker. But essentially, the person's history was they showed up to an outside surgeon. This is the only image that I have from before any surgeries started, but this was seen, and it was assessed to be osteomyelitis. We all know now that it is not, and it was treated for osteomyelitis. So here was the fixation from that. So that would be it's got some transitional anatomy. We're calling this L2-3. So at this point, the patient starts following up, and we can see that there already is some failure of this construct within 2 weeks of the surgery. And here it continues to fail. And so we're seeing, kind of those stigmata of Charcot arthropathy, growing there on the right side.
If you can stop there for a second. Jack, if you assume that the neurostatus reporting was correct, how can you explain a wheelchair ambulator breaking apart at what I see as L12 like this? And why would this construct just fail like this? What happened here, mechanically speaking?
Well, it's just a mechanically poorly planned construct. There's not good anterior column support. Even though if this was addressed appropriately early on, it would have been a lot easier to get a fusion across that with intracavitary curettage. But at this point, you have a deficient anterior column with a progressive dissolving disease and a single level construct with a pretty short and small pedicle screws. So sort of doomed to failure with even in a neurologically healthy person, this would have a tough time healing, but certainly in someone who is neurologically not normal, it was doomed to failure from a carpentry standpoint, if nothing else.
Great. Carry on, Jared, in interest of time.
Okay. So at this point, the patient presents to us, and this is identified as being Charcot arthropathy. This construct is not going to hold up, and really with this progressive deformity that he's having, went right to something that is significantly more stable. Went T5 to pelvis with a quad rod construct. So we're bridging that Charcot area. So at this point, this is what the patient has, and now the saga continues. So at this point, the 2-3 and 3-4 are further reinforced, giving some sort of a healing surface. So lateral cages were placed 6 weeks after the initial surgery, just give them a better chance. And unfortunately, comes almost a year later, and now we're seeing some loosening of the S1 and the pelvic screws that we can see here. So, starting to get some failure of fixation. At this point, patient is revised. We've changed up that quad rod construct, but still stuck with quad rods. And now we are going into the multiple pelvic screw territory. So we've got 3 over there on the right side, 2 over on the left. We have the the quad rod construct with slightly staggered to distribute forces, still bridging that area, but also the that pseudoarthrosis region that he had. So we keep following him, and then comes in more more lucency of these screws. And then if you're able to see down there on the image on the left side, that rod is no longer attached to the part of the rod that's in the pelvic screws. So now we're getting rod fractures. So area is further reinforced. So at that point, an attempt was made to do interbody fusions down at we're calling L45, L5S1, and hardware replaced, rods replaced, screws exchanged, and the hope is, all right, we're going to heal this, right? So pseudos down at the very bottom, as we can see here, as well as some screw loosening. So plan at this point, let's try to reinforce that. So a revision was done. It was a revision ALIF. Cages removed from the front, large allograft bone blocks placed. You can see one of them ended up fracturing, but that was that was the progress there. So from there, at the next follow-up, we see that we have more rod fractures, all the way at the bottom associated with the pelvic screws, as well as, lucency surrounding the pelvic screws, so just further loosening. This one was, he felt a pop when he was getting out of a car. So it's more pseudoarthrosis. So then, finally, patient, let's see. So at that point, revise again, more hardware exchange. Now we have 3 pelvic screws going in on that left side, upsized on the right. And so the plan, hopefully this stays, stable, right? So, yeah. So then, well, he manages to pop a rod out, take those locking caps straight off, just further pseudoarthrosis. So is anyone starting to see a pattern here with the Charcot spine? We're throwing the kitchen sink at him at this point, trying to get him to heal, keeps pseudoing, keeps being unstable. So then most recent attempt, at reinforcing the hardware, hardware exchange, switch up the quad rod construct, a little bit bigger screws, bone graft, but this is where we are now, and so far, at least, in the last 6 months, it's doing great. Haven't heard anything additional. So I guess at this point, is there anything else that anybody would have tried there? Is there?
So we're running out of time. So let me just fast track it. This is a horrifying case, and again, I was actually not aware of this patient. So let's start with Izzy. Izzy, in these final minute projection, what should have been differently?
Two quick comments. I don't understand the rationale for the first revision going all the way top to bottom. I suspect I would have tried to treat that with a more focal anterior posterior reconstruction, leaving the lumbar spine mobile for this individual. The second point is, as you're going down the road with all those multiple revisions, did at any point someone do some cultures to rule out any kind of occult infections? Because we get this tunnel vision, Charcot spine, Charcot spine, Charcot spine, but some of these revisions were pretty quick, and I wonder if there was something else going on that we may have missed.
Cultures were taken, standardly with each revision, and none of them grew anything.
Good, super.
Jack, do you want to close us out?
Yeah, I mean, just, better decision-making with the first surgery might have saved this guy a lot of aggravation and metal. This is kind of a stone rolling downhill, getting bigger and bigger and bigger as it goes down. Your problems start to multiply, and we can kind of see the result. But it's a difficult problem. These are tough patients. But if you're aggressive focally and strategically at the beginning, you can obviously save a lot of aggravation later on.
And Dave Pauly, Minnesota. So without mentioning names, but you've done a lot of work on better pelvic fixation. Would better pelvic fixation have possibly avoided this, or is this just a real problem?
Yeah, so a key thing we learned in our acute pelvic fixation failure papers, both a single center and multi-center, is it's not the number of rods to the sacrum, it's the number of rods connected to fixation in the pelvis. So in this case, you started out with just 2 rods connected to the pelvic fixation, and that our experience in high demand, and any paraplegic is obviously high demand, I would look for 4 pelvic screws, whether they're S2AIs or iliacs, and 4 rods to those pelvic screws. If you offset the caudal screws more medially and the cephalad screws more laterally, it's really easy to make that construct connect, and that we've seen better success with that. And that's been our salvage strategy when we've had failure, and we've not had any failure when we've had 4 rods to 4 points of pelvic fixation. caveat yet.
Awesome insights. I want to thank all of our great discussants and fellows. And big hint for tomorrow night, we have an inaugural session, an evening with a spine surgeon with none less than Alex Vaccaro. Dr. Ziegler and I will host that. We hope many of you will take the time to come and join us for that and add your commentaries. Thank all of you in the audience for joining us. We had a great attendance tonight on Valentine's evening, and I wish you all a happy conclusion of Valentine's Day.
Great job, Jens. Thank you, and Rod and Dave Polly. Thanks for joining us. It's good to see you. Stay well, everyone.
Good night, everybody. Enjoy.
Thank you, Izzy. You too. See you tomorrow.